I appreciate the opportunity to be here with you today. I also appreciate the opportunity that I see so many of my former infectious disease companies that were clients after I left the Hill, Bayer, Chiron, now Novartis, Schering-Plough. So it's an opportunity to work with people I've worked with before on these important public health issues. So thank you. I thought I would pivot my remarks just a little bit. First of all, let me preface it by saying I understand as the last speaker, my job is to be brief and to be seated, and I intend to do that. So I just thought I would pivot my remarks a little bit and pick up on the conversation from earlier this morning and talk to you about how I think Chagas will emerge as a public health policy issue and what hooks may work to achieve that based on my own experience with hepatitis C. Let's talk about the current Chagas policy landscape. It's currently recognized as a blood safety issue along with hepatitis C, and that's important because they evolved, in my opinion, at the same time in congressional oversight hearings and reports going back to 1995. Blood safety advisory committees in both the United States and Canada have considered the issue of T. cruzi transfusion transmission since 1999. There's been little dedicated legislative activity to Chagas, but some recognition in overall tropical disease legislative efforts, including the priority review vouchers and neglected in some legislation like Neglected Infections of Impoverished Americans Act. It was first introduced in 2011 and has not yet been passed. And all it's asking for is a study. So I would say, looking at this is a tremendous opportunity to make a big difference in public health. I did want to talk a little bit about the comments that were made earlier today about why can't we get Chagas recognized and get patients activated. And I know that it's been addressed very succinctly by physicians and from other treaters who were involved directly, but I wanted to give you a policy perspective on this, which is, let me say that I was at FDA during the HIV years when those patient groups were very active, and we had to have security every time there was an advisory committee meeting. I was working on the Hill when, and in fact, led the investigation that brought hepatitis C to the forefront as a blood safety issue and as a public health issue. So I have some experience with these public policy issues and what it takes to get them to emerge. And these are my thoughts on it. In terms of HIV, those patients knew they were infected. The hepatitis C and the Chagas patients don't. I think that's probably the biggest differential in trying to activate patients. Now, not everyone knew of their HIV infection, but the ones that got active politically and were able to change the FDA review system, those patients did know it, and they were knowledgeable about how to levy political activity to achieve their ends. That has not been the case with the hepatitis C patients. Going back to 1995, they were completely unaware of their infection. There was some activity, some recognition that it was a public health issue for organizations like the American Liver Foundation, but they never got to the point that the initial HIV patients did. And I think in terms of Chagas, you're sharing with hepatitis C the social stigma associated with the disease, as well as the lack of energy and focus at a federal level in the U.S., and a lack of knowledge about political action. So in my opinion, your best model here is hepatitis C, not HIV. But I'd be happy to debate that with you later. As I said, there were a series of blood safety hearings that began in Congress in 1995. Both hepatitis C and Chagas emerged as issues in that investigation. There were several reports of the Congress. Oversight reports are passed by the full House of Representatives as if they are legislation. They are then considered to be directives to other committees of the Congress to legislate based on those findings. I wrote those reports, but that doesn't mean you shouldn't read them. And the first one, infectious agents in the blood supply, specifically mentions Chagas as an emerging bloodborne infection. then there was continued in an investigation. There were a lot of activities, a lot of touch points with federal officials. I think the most dramatic for hepatitis C after the release of the report in 1998 was March 5th, 1998 was the first congressional hearing on hepatitis C. Surgeon General David Satcher testified. CNN broke in live to cover that. That's very unusual for that kind of a hearing. And he agreed to notify all recipients of blood products who may be unaware of their infection. So there was a similar letter that had been sent by Surgeon General Koop regarding safety of individuals who may have acquired hepatitis or HIV through transfusion when we started to recognize that infection and before we had actually committed our blood supply to testing. So we were asking him to do the same thing. I think he wanted to do that. However, through a series of unfortunate events that I won't go into, but would be happy to talk about later, that never happened. That letter was never mailed. And the blood banks and the hospitals did some kind of look back, but not well, for a variety of reasons. Among them, that they claimed they didn't have the records, although they managed to bill all these patients, so I never really understood that. But they also had some liability there and were concerned about the impact that the knowledge of an infectious agent in the blood supply would have on other donors. There was a commitment on the part of HHS, particularly CDC, to conduct billboard and ad campaigns that would notify individuals who may have received transfusion. That was done in extremely limited distribution, and it was a point of contention between the Congress and the agency. Around 1998, there was a change in the chairmanship of the committee, and that chairman went over to the Department of Veterans Affairs Oversight Committee, where for a period of 8 years he continued to enforce notification on the Department of Veterans Affairs. And there's a considerable incidence of hepatitis C in both Korean and Vietnam era vets. As a result of his oversight and his commitment to the issue, the VA was the leader in notification for the federal government. HHS, not so much. There were a couple of NIH consensus conferences between 2006 and 2014, but not too much activity that I would say was really definitive policy-wise. And then in December of 2013, FDA approved Harvoni, and Gilead started to launch unbranded disease awareness and branded advertising campaigns, which seem to have been much more aggressive in the last 2 years. FDA summarized very nicely in their guidance to industry, and they've got several on Chagas, what they have found so far as the risk in the United States through transfusion. And potentially 10 cases of transfusion-transmitted Chagas and 5 cases of infection from organ transplantation have been documented since 2013. And I think we all agree, and in fact, elsewhere in their website you can find an acknowledgement that there probably are more cases than that. In terms of current blood safety issues related to Chagas, blood centers began testing donors voluntarily in 2007. Voluntarily means some do and some don't. So technically, you could live in an area where they test or an area where they don't, and your risk is not equal in distributed throughout the country. That is a policy and an ethics issue, both for public health and also for the way that the industry is viewed commercially. But more than 2,000 infected donors have been identified. Now, these are individuals who are inclined to donate. They're usually a subpopulation, very limited subpopulation. I don't know that you can extrapolate general amounts of infection, but I think it's a relatively high number than what we might expect. Blood components with the greatest risk of transmission are whole blood and platelets, and there's a high mortality in acute transfusion-transmitted infections when recipients are immunocompromised. That happens to be most of the people who get blood in the first place. So the impact on the safety of the blood supply is significant when it occurs. There are some pathogen inactivation systems that are available and are currently licensed by FDA. They're not currently required, and they're implemented selectively by blood centers. Again, that raises the issue of, is your blood safer in some locations than it is in others? There have been some interesting estimates on Chagas in blood donors. 1 in every 27,500 donors in the U.S. is infected. But that's not universal. 1 in 6,500 blood donors in Texas is infected. And 1 in every 3,000 donors in South Texas is infected. And then 1 in every 2,000 blood donors in Los Angeles is infected. And Dr. Richard Benjamin was a former chief medical officer of the American Red Cross. He also served with me on the advisory committee on blood safety and availability at HHS. And now he's the chief medical officer at Cirrus, which makes the pathogen inactivation systems. But his quote from the Dallas Morning News is still relevant, I think, despite any commercial taint here. It's a very high number, and it's higher than hepatitis C or HIV. So these are the lessons that I think we learned from hepatitis C policy. Despite other means of infection, public policy recognition of infectious diseases, at least from my experience, has resulted in identification of the agent, or it was resulted from identification of it as a bloodborne pathogen. Frankly, nothing gets media attention like a new threat to the blood supply. It's partly conditioned by HIV and hepatitis C and hepatitis B as well, but it is something that really does seem to interest media. Public policy support, however, for infectious diseases is variable and inconsistent in both legislative and regulatory sectors. And despite congressional hearings, oversight reports, media coverage, including breaking in live by CNN in 1995 through 1998, hepatitis C was recognized as a general public health threat by individuals who are theoretically infected or likely to be infected, only after Harvoni was approved and branded and non-branded advertising campaigns were initiated in 2014. So in conclusion, I think that infectious diseases are often first identified in the public policy arena as threats to the blood supply. They can provide significant media coverage, but not sustained public policy or government interest. Good treatment options provide energy and focus for physicians, patient groups, government, and media to identify patients. I think they're highly reluctant to do that if they don't have some kind of therapy to offer. And disease awareness campaigns undertaken by pharma companies have served as the vehicle, at least for hepatitis C and HIV, by which public recognition of a widespread infectious agent is achieved, and that is not being done by the U.S. Public Health Service. In short, I think Chagas is a problem that needs a solution to chase. Once that happens, I think it'll be much more media awareness will be greater. I think patients at risk are going to say, oh, wait a minute, my mom was from Peru, or my grandmother was from Peru. Maybe some of these symptoms shouldn't be dismissed as just, some other condition. So with that, I'd be happy to take any questions, and thank you for your attention.